Good evening, everybody. I am Dr. Samir Joshi, Professor and Head ENT, BJ Medical College, Pune. I welcome you on behalf of my senior colleague and consultant, Dinanath Mangeshkar Hospital, Dr. Sachin Gandhi, on this wonderful evening. At the outset, I take opportunity to welcome the prominent figures associated with this webcast, Dr. Vasant Oswal, Dr. Rao and team from UK, Dr. Manish Munjal and team from Gangaram Hospital, Delhi, Dr. Rakesh Srivastava from Lucknow, Dr. Manjunath from Bangalore, and Dr. Rakesh Datta from AFMC. And of course, there are so many of my friends who rang me that they are online. We have a beautiful relationship. We as ENT surgeons have a beautiful relationship with anesthesiologists. It's a relationship filled with awe and respect, both of them, because we share the space as well as safety. So safety is a concern for them, space is a concern for us, and how to manage this tug of war is a dilemma always. That's why anesthesia is so special in ENT. Along with that, we are having an anesthesiologist who is specialized in OPD anesthesia. It is yet to come in India. So it's my pleasure to introduce to you Dr. Sarang Puranik, who is our first speaker. He is an anesthesiologist from Kingston Hospital, Surrey, associated with NHS UK. He is consultant anesthesiologist working there since last 18 years. He is a lead in airway management there, and his specialty is simulation and regional anesthesia. But on the top of that, he is the alumni of the same college which I'm heading, that is Sassoon General Hospital, BJ Medical College, Pune, and he was president of Art Circle there also. So I welcome Dr. Sarang Puranik here and requesting to start the delivery.
Thank you very much. So I thought we'll start with something which we do on routine basis. And the first talk is related to, as you probably have seen this, ENT day surgery, anesthesia and surgery, and use of Thrive in small DGH. Obviously, we have eminent speaker soon, followed by me, Anil Patil here with us, and he is going to talk a lot more about Thrive. So what I will do perhaps is we'll talk about how we are using Thrive in our small hospital, which is about 400-bedded hospital. So I'll start with what I'm going to talk about in terms of day surgery anesthesia. So what sort of surgeries as we do as day surgery, because most of our hospital ENT surgery is now done as day surgery. How and which patients are selected, what type of surgeries are done, what are the criteria if you are going to do any kind of day surgery, anesthesia and surgery, and some of the pearls of wisdom as well as some of the pitfalls. So going to, I don't know whether you can see this slide, but this is the definition. It shows definition of day surgery anesthesia. And as you can see, day surgery or ambulatory surgery anesthesia is where you operate on the same day and the patients are discharged on the same day, which is fairly obvious. And I'm sure you will be able to see the types of surgeries we do. And a lot of those patients we operate, or rather all of them will go home on the same day. In most of the Europe, surgery anesthesia is practiced quite a lot. We have a lot of problems with regards to beds for the patients, and we're fighting, all the specialties are fighting, and the hospitals have been closing down beds and all that, and it's a huge problem. So day surgery anesthesia is huge, and more we can do. Every decade, the day surgery anesthesia numbers are growing, as we can see. So this is just to give you sort of idea of what you mean by day surgery anesthesia. Of course, in some cases, if you need to, what is called as extended recovery, where patients can stay almost 24 hours, but not completely, so they can be staying there just before late night, and they can still go home. So that is called as extended recovery, and some places will operate as recovery, 23 hours recovery. So what are the common types of procedures we do? We do all ENT, essentially ears, nose and throats, and common procedures which we do are listed accordingly. So grommets, tympanoplasty, laryngoplasty, stapedectomy, mastectomy, foreign body removal, and BAHA. These are all sort of very commonly done procedures. And then in nose, face, septoplasties, fracture nose, rhinoplasties, and polypectomy, etc. They're all done in nose sections, and throat, tonsillectomies, adenotomy, diagnostic, various endoscopies, direct laryngoscopies, and vocal cord polyps, etc. as well. So this is just sort of some of the common types of surgeries which we do as daycare surgeries. So what are the advantages? Obviously, the advantages are quite a lot to the patients. It's all based patient-related and patient-centered. They can get much more personalized care because they don't need to be looked after by, in a big ward with one ratio of one nurse to 10 or 20 patients, etc. They get much more personalized care. They get to go home and return home and recover in their familiar environment, and they can continue their medication as usual. The post-operative pain obviously is going to be an issue if you are thinking about that, but the way we look after them, that is hardly an issue because that has been taken care of quite well as nausea and vomiting, which I'll talk about. It avoids prolonged hospitalization, as we said, and early mobilization has advantages in terms of avoiding DVT. And because, as we said, adenoids and tonsils being the bread and butter, you get much less problem with the parents being, children being separated from the parents. So that is also much nicer for whole family, if you can see that. But what is important is doing the surgery, maybe the last bit within all this structure really. What is important is what we do before and what happens after. And actually, if you can get that, then you can do all the surgeries quite easily. So, the surgeon's role is important, but equally, all team role is really, really important. So it starts from preoperative assessment. It is important who does the preoperative assessment. So most of the assessment is done by the nurses, and preoperative training is given to nurses, as well as the anesthetists are doing clinics where they will see any complicated patients, etc., and select which patients can be sent to daycare and which patients can be inpatients. So that selection happens right from the beginning, and it could be even 2 months before. And then a lot of them can be done online or even by postal questionnaires. So if they're completely fit and healthy, for example, they don't even need to come to hospital. They can be done by questionnaires. And if all the questions are simple, then say 1 and 2 patients can be done easily without even patients coming to hospital. So that avoids all those issues of coming to hospital, transport issues, parking, all those sort of things. And I'm sure when I was talking to Dr. Gandhi, he was saying those same issues are cropping up here as well. And I think Dr. Patil, who has just arrived from UK, within last 2 years, he must have seen the traffic. And those issues, I'm sure, are all over now. And only other issue is that when we get referrals from outside, that can be a bit difficult. So the patient selection is important, which I'll come to that in a minute as well. So what are the anesthetic considerations? We can do TIVA, which is total intravenous anesthesia or inhalation anesthesia. And that is, again, it's choice and personal choice and institutional choice as well. With regards to airway, most of the airways we use, or most of the surgeries we do are nowadays done with the help of flexible laryngeal mask airways. And when I asked about availability here, I have a feeling, I don't know whether the things have changed recently, but certainly they're not that easily available here, and flexible LMAs are not quite commonly used here. And that has, to me, and I'm sure a lot of people in UK and Europe will agree, that almost revolutionized the way we anesthetize these patients. There are a lot of studies to show that it has got superior profile, and we do majority of the cases with flexible LMAs. Important issue, as Dr. Joshi said, share airway, contamination of airways. all those things can be actually handled quite well with the help of flexible LMAs. And the recovery is smooth, so we don't need to keep patients waiting until they extubated. We shift them, for example, in recovery with the LMA in situ, and the trained nurses look after them. So that avoids and reduces the time for the surgery and post-op as well. But important things are during anesthesia, how we look after analgesia. Relaxants, again, with the help of flexible LMAs, we call them. My surgeon, for example, uses a lot of nerve monitoring when he's doing mastoid surgeries and all. And for them, we can't use muscle relaxant. So this avoids muscle relaxant completely. We can use them without muscle relaxant, and patients can be monitored quite easily. So that is a great advantage. We need to choose right analgesia and antiemetics. Analgesia, we rely quite a lot on local infiltration, and those things are really, really important because, as we said, if the patients have pain and nausea vomiting afterwards, they can't go home early, and then defeats the purpose of daycare anesthesia. Use of nitrous is there. Again, I'm sure all the anesthetists who are involved in ENT surgery know when to avoid nitrous, and that will again reduce the avoidance of nitrous will reduce the incidence of post-op nausea vomiting. Another issue is laser surgery. The ear surgeon whom I work with, he uses this ATP laser, which is the diode laser, and I don't think that is very common all over, but he finds that is really useful. And for that, he actually says we use goggles, but he doesn't think that even goggles are needed. So it's not a huge problem really. And you can still use laser in day surgery. Throat packs, again, a lot of papers recently have said that we don't even need to use throat packs because it is not necessary, and a lot of secretions can be suction, which remain outside the laryngeal mask airway, and that can be easy. And another issue is we need a lot of trolleys. The population is growing in size, certainly in all over Europe, and perhaps here as well. So we need appropriate, for example, bariatric trolleys for bariatric patients, etc., and trained staff for all throughout, as well as pre-op, intra-op, as well as recovery. We have to use strict discharge criteria. Routine checks are important, but make sure that there's no immediate complications. Pain relief is sorted, and the escort and travel distance is really important. They need to have someone to take them home, but the travel distance, the important issue is that they need to be within certain distance that they can go and come back if necessary. So that is really important, that if you're selecting the patients who are 10 miles away and they can't get back if you need to, so you have to be considering all those issues. So they need to be able to come back within half an hour if needed. So that is really important criteria. So having said that, there are things which we have to be aware of. Please let me know the timing. Okay, sir. Cancellation of the day can be an issue. So if there are issues which you're not picked up even after all that, sometimes the patients are referred from other hospitals and they're not selected properly, so they could be a certain number of cancellations on the day. Again, some anesthetic consideration could be there because of their recent cold, etc. Again, the criteria are loosened for that as well, and we don't cancel patients that easily these days when they have cold, etc. But still, there are issues which can miss, so we need to be considering all those things. Readmission, as I said, the distance and obesity being a big problem. So tonsillar bleeding, we don't see that often because I think I have mentioned that, but surgeons are using more of coablation. Surgeons within the audience probably know coablation advantages and disadvantages. I wouldn't dare to comment on those things, but certainly probably that has reduced because I believe the surgeons say that you don't really take out the capsule and things like that, and the bleeding is much less, but they are quite meticulous. Obviously, we probably will get 1 or 2 patients who bleed post-op, but they are looked at, generally they are within first 4 hours. The patients don't go home. So we select the tonsils first on the day so that they are done first on the list so that they don't get, to go home for 6 hours at least. So that is also important. So the selection of the timing of the surgery is important. And as I said, you can't deny, but we will get 1 or 2 bleeding post-op, and they are looked at immediately most of the time. So I think with this, it is very easy, and we've been doing it for last more than 20, 25 years now, and our hospital is probably one of the biggest in terms of day surgery, anesthesia, and ENT. Out of 4,000 or so day surgery total, we do about 1,500 to 2,000 ENT surgeries, and every day there is 1 or 2 theaters full of these ENT patients. So, and that is in spite of the number of tonsillectomies and grommets going down, because we have very strict criteria, as Anil probably will agree with me, that we have to ask for special funding, and they are not done as many as we used to do before. So that was just a short introduction about day surgery and ENT anesthesia. Thank you very much.
Wonderful presentation, Dr. Sarang Puranik. To summarize for our audience, there were so many new things here. One was distant questioning, postal pre-anesthesia checkup. This is wonderful, novel thing for us. So many of the things can be sorted out pre-operatively, and category 1 and 2, he said, can be taken up directly for surgery without much of a fuss. Then it is meticulous pre-medication. Nausea, vomiting should not be there at home. We are not habituated to send the patients, but nowadays we observe that. Strict discharge criteria, escorts, knowledgeable escorts distant from the hospital, and obesity and other morbid conditions. These are important factors as far as anesthesia, ENT, and daycare is concerned. Thank you, Dr. Puranik. Now, our second guest speaker is Dr. Anil Patil. He is a senior consultant at ENT Hospital, London. So it's one of the biggest ENT hospitals in, shall I continue? Yeah. Biggest ENT hospitals in London. He is head of the Department of Anesthesiology there. And he is ex-president of Difficult Airways Society of UK. He has more than 100 articles in various articles, papers, and chapters in books. And he is an international authority on Thrive, that is transnasal humidified airway management for him. So let us welcome Dr. Anil Patil here, please.
Thanks very much. Thank you. Thanks for inviting me. Dr. Gandhi, thanks for organising all of this. And Dr. Sarang and colleagues, thanks for having me here. I've just arrived. I've come from London, Mumbai, Pune, Pune here. Direct, straight from home to here. So I'm going to talk about, I was asked to talk a little bit about ENT anaesthesia, just kind of an overview of the sort of things that we're doing. I always declare that I've developed a video laryngoscope, and I've had travel, accommodation, consulting and research funding from Fish and Paykel Healthcare, who make the Thrive equipment. So just, no one will know who I am, but just sort of fill you in. So I've been a doctor for 29 years or so, 28 years. I've been a consultant for 20, and in that time in the ENT hospital, I've personally anaesthetised just over 6,000 airway procedures. I've anaesthetised about in excess of 1,000 what I call critical airways. So that is either airway stenosis or tumours or radiotherapy or obstruction. We have an interesting group of tracheal stenosis patients and glottic stenosis patients who come in electively with stridor. So there's quite a few stridor patients. And probably the most interesting thing is where it's all gone wrong, and I've run into problems, and everybody has problems, and I've had problems, and that's where I've really learnt a lot, which is this, what I call 50 interesting moments, and I'm sure we've all had interesting moments in our careers. So in terms of people that I work with, so this is Professor Paul O'Flynn, who is actually a professor here at this institute. He's very high up in the Royal College of Surgeons, and he has an affiliation here. So he's a head and neck surgeon, so I do a lot of head and neck with him. This is Professor John Rubin, who's a phonosurgeon. So we do a lot of laryngeal nodules, papillomas, sulcuses, vergatures, etc., etc. Guri Sandhu, who is also, I think, been here a number of times, and he really is a world authority on airway stenosis. I've worked with him for over a decade. I don't work with him anymore just because he's moved his practice slightly, but I know him very well. In fact, I had a long conversation with him last night. He is a true airway surgeon. Khalid Ghafoor, who's one of Guri's colleagues, I work with him, and occasionally with Martin as well. So that's the group of people I work with. That's obviously the sort of stuff that we do. These are things that you're all very familiar with. So normalish airways with a bit of interesting pathology, quite interesting airways anesthetically because the hole's getting small, and then very interesting anesthetically because these are the sorts of patients, tumours. These are all pictures I've taken. This took me years to get. This is a cherry red epiglottis, as you see in a kid, and then tumour cases, obviously. So I'm going to talk a little bit broadly about some of the issues that we've had with them and what we think is a sensible way. The other thing to mention, of course, is that when we talk anesthetically about difficult airways, so there's one bit is at the laryngeal level, so how tight is the hole, and there's another aspect to it, which is that the difficult airway can be not just because there's a problem with the hole here, but it can be because the patient's head and neck is distorted, and so we have problems accessing that area. And this is obviously similar patients you're familiar with. So radiotherapy patients, inside, everything's pretty normal actually, but they can't move their neck around. Rheumatoid patients, post-flap patients, they all have subtly different problems with the airway, which require a slightly different response from an anesthetic perspective. In essence, broadly, we can classify problems into a big problem up here, so tumour, distortion, whatever, so we can't get access to the airway. We can have problems down here, which is largely the ENT realm, where you might not be able to get a tube down because the hole is too small. Or this area here, which is actually quite a tricky area, which is a sort of vallecular, epiglottic tongue base area, where as that starts to expand, as you know, patients can present with some symptoms, or they can be completely asymptomatic, and then you put them to sleep, and suddenly this falls back, and then you start putting a metal blade in here, and then it traumatizes, and then it swells, and then it becomes edematous, and then things turn into a vicious cycle, and it can be. So just being aware of all of that is very useful. So awake fibre optic intubation is a fantastic tool, and we use it anesthetically for the right patients. In the UK, we don't use it as much as we should do, and that's largely because although the equipment is available in most hospitals, you're generally going to use this technique if you need to use it, or if you're really interested in it. And the reality is that most anaesthetists don't usually need to use it all the time, or are not interested in it. So you end up in a situation where this is a fantastic tool for the right patient, with the right anaesthetist who can do it, and we probably need to get to a position where we need more people doing it in the right groups. So this is probably the most significant awake fibre optic I've done. So this lady's got terrible rheumatoid, but also her sternum is at her chin. So there is no option for a surgical airway. If you put this patient to sleep and it goes wrong, it's not going to end well. So there are definitely situations where an awake fibre optic is very useful, and I think we all recognise that. It doesn't always work. This is some data from the NAP4 study, which was a very big audit of all airway practice in the UK, looking at death, brain damage, and emergency surgical airways. So it's the largest of its type. Looked at 2.9 million general anaesthetics, and these were the sort of the things that we were finding. So it doesn't always work, and it doesn't work for this sort of reason. So you're all familiar with it. If you have a big tumour here, then the pathology gets distorted. So if I saw a big tumour here, I would go poking in around here, thinking, well, the airway must be underneath there somewhere. But actually, the airway's over here, and it's been distorted. The tumour's obviously been laser resected now. So it's not always as the pathology starts expanding, the tissues distort, and you can think you're in the right place and you're not. So it's and this is, I think, is a video that shows that, yes. So surgically, you'll all recognise, but anaesthetically, it's quite easy with a laryngoscope looking directly in to think, oh, well, this must be where the airway is, because there's some bubbles coming out, and it looked like it's the right hole. And this is someone who's obviously had some tumor resection and some radiotherapy. And you could imagine that there's an arytenoid there and an arytenoid there. Of course, it's in the wrong place. This is actually the airway. So it's very easy with distorted anatomy to get confused. So the only real way you know you're in the right place is if you can see carinotracheal rings, and obviously with capnographic confirmation. This is another interesting case. It illustrates a couple of things. One is, again, that you can quite quickly find yourself in a problem. So this is a very senior colleague of mine many years ago who called me to say, can I have some help? And this patient was totally asymptomatic. And you look inside, and it's just a bit of a mess. And if you use a fibroscope, you might think that this is the epiglottis here, or maybe this is the epiglottis here, or maybe this is the epiglottis here. And the reason you think that is because with a fibroscope, you have a very small visual sort of field. And what's useful is to combine, in these very tricky airways, a global view, which is a video laryngoscope, and then focus in with the fibroscope, because the global view will tell you that actually that doesn't look quite right, but there's bubbles coming out here, so maybe that's where I need to go. There's interesting some interesting papers coming through on all of this, but again, this is something I suspect it's a sort of specialist interest to a few people that are interested in this area. This probably immediately is not going to translate sort of globally. We do quite a lot of what's called jet ventilation for airways. So the surgeons that we work with, so Guri, for example, Paul, if we're doing tracheal work, then they don't want anything in there. So we jet ventilate, and you're all familiar with that, I'm sure. You can get problems with that. This is a patient with Paul, actually. We're outside having coffee, and this is a trainee surgeon, trainee anaesthetist, and over a period of time, as we're supraglottically jetting, the anaesthetist, the trainee says that, oh, I'm having problems ventilating. So we come back in, and indeed, there is no ventilation at all. And what has happened is that the blood that the surgeon's been operating, and the blood has been trickling, and the jet has pushed and pushed and pushed, and a cast has formed around the trachea, and over a period of time, that blood has blocked off. Now, the reason I mention it is because this is a really scary situation, because you've gone from being okay to being not okay, and not okay in the sense of you cannot ventilate this patient. So whatever you do from the top end, you put a mask over and you bag. All you're going to do is compact that tracheal clot. So you just need to be aware sometimes that, especially with operations up here, that it's always just worth checking down there that it isn't plugged off, and that's the cause of the problem. There's obviously problems with jet ventilation. So I've jet ventilated just over 4,500 patients, and I've had 12 barotraumas in my time. One very severe bilateral tension pneumothoraces, surgical emphysema, and pneumomediastinum, which needed immediate chest drains to resolve, through to things like this, where when you're jetting during the case, you notice that there's a bit of desaturation, and then it settles again, and there's a bit of desaturation, and then it settles again. And most of these cases resolve, but there is a danger to this technique. We'll sometimes, this is again I think a case with Paul, where we sometimes put in transtracheal needles when we're really worried about the airway at the top end, where we do not think we can get a tube down. And indeed, sometimes we try and we cannot, and therefore that we ventilate through there while we do a more formal tracheostomy. And then I don't think you can hear this. I don't know if there's any sound here. So what this is a patient who's been transtracheally jetted, and the trainee surgeon has blocked off the airway. And what you can hear is we've jetted, the lungs have gone up, and now the air is coming through this tiny hole, and you can hear it hissing as it's coming through. And of course, if you jet on top of that, and when the lungs are up, and you jet again, then that's when you're going to cause the barotrauma. So it's just worth. Barotrauma is a real feature of that. Airway obstruction. So when we're dealing with anything down below, stents, whatever, if you go from being able to ventilate to not being able to ventilate, you've got to think that maybe there's something plugging off down below. Now, awake surgical airways. So one of the things that that we all do, I think, is if the anaesthetist says, "I don't fancy this. This is a really bad airway. This patient can't lie flat. They can't really breathe. They're really stridorous. They're tachypneic. We know there is a massive tumour here. It is unrealistic for us to expect to put a tube down. We are going to do an awake surgical airway because I don't think we can intubate this patient." So we agree to do that. It's a very difficult thing, I think, actually. It's very difficult for us because we stand there and do nothing. And it's really difficult for you because you have to then put this patient who's in extremis, put them flat, and they don't always want to lie flat. And then you want to put them back, and they don't really like doing that. And on top of that, they're tachypneic, and on top of that, they're hypoxic, and on top of that, they're septic, and on top of that, they're unwell. And then you make a hole, and then you start rummaging around. And most of the time, it goes in the right hole, but sometimes, I've seen it, it doesn't go in the right hole. And there'll be this sort of slight standoff where the surgeon, and it's usually a trainee surgeon, says, "I'm in the right hole." And we connect up and we say, "Well, no, I don't think you are, because there's no CO2 trace and it doesn't feel right." So we just need to be on the same page for that bit. It's a really difficult thing, actually. It's one of the most horrible things I think we do. It's certainly the most challenging for an ENT surgeon, for a head and neck surgeon. And certainly in the UK, because of percutaneous tracheostomies, there's a whole tranche of consultants coming through now who have hardly done any of these. And they're going to have to do it when they need to do it. So it's a problem because the trainees coming through that are now new consultants have just not done them as anywhere near the numbers. But we'll get through it. One thing that does help is high-flow nasal oxygen. So this is a case report, but there's a number of reports coming through in the literature whereby by putting on high-flow nasal oxygen with a patient breathing spontaneously, their tidal volumes are improved, their ventilatory rate is improved, they're less hypoxic, they're less hypercarbic, they look more comfortable because they can breathe, and so the positioning and the movement is a little bit easier. So this, I think, adds in an extra margin of safety. And in the UK, we're just trying to pull all these reports together to try and come up with some sort of UK guidance on that. Inhalational induction. So in our practice, we don't tend to do these for critically obstructed airways because we just think it gets worse. And the reason it gets worse is illustrated by these two patients. I mean, this patient, the first one's got had some surgery done. But basically, if you try and breathe a patient down who's in extremis and is obstructing or obstructed, basically the airway gets worse and the seesawing gets worse and things generally deteriorate. And what you end up actually doing is that you end up taking over ventilation. And if you take over ventilation, that's no longer spontaneous breathing. And I think that's what generally happens. Again, in that group, there's some literature coming through saying that if you put high-flow nasal oxygen on, it really helps that group for the same reasons that I said. It acts as a pneumatic splint. It keeps the airway open, and it improves the tidal volume, the oxygenation, the CO2 removal. Tracheostomy problems. I'm sure we've all had tracheostomy problems. I've had 5 times where we've had to put in an emergency surgical airway. Both of these, I think, are with Guri in patients that have had weird and wonderful airway reconstructions. The one thing I would say is that even as somebody who is pretty experienced with airway work and a surgeon who is world-class in airway work, when you get to this situation, I don't think it matters how experienced you are, a lot of the kind of subtle, complex thinking goes out the window. You have to go back to absolute basics and essentials, and it goes back to simple things. So you make a simple decision that this patient is not breathing, we are not going to get anything to the top end, we need to do this urgently, number one. Number two, that the equipment should already be there, and you just choose a simple way of doing it. And for most surgeons, most of the time, not specialist head and neck surgeons, but for most surgeons, most of the time, that involves a scalpel type technique. So in, through. The subtleties around small needles, fine catheters, jet ventilating through there, I think are complex when you're trying to do something in a life-saving situation. The most important thing, whenever you get stressed, there's some fantastic physiological work which shows that as you get stressed, and I maintain that it doesn't matter how experienced you are, when someone is blue and is about to die on the table, you are stressed. I have been stressed, you are stressed. So when you're stressed, your heart rate goes up. You cannot help, your heart rate goes up and up and up, and when you get to a heart rate of about 120, 130, subtle things change. Your hand starts to shake, and you go through a fine tremor through to quite a gross tremor. And you cannot do anything about that. That's the adrenaline stress response. So you need to try and keep everything really basic and simple under these situations. So complexity is not the thing to do when we are stressed. And that's why in 2015, when we wrote the Difficult Airway Society guidelines for unanticipated difficult intubation, we specifically, that we knew that there were so many different ways of doing this, and we recognized that as a country, for the UK, it would be better if we decide on a simple technique and it's available everywhere and we all learn how to do it, rather than have lots of different techniques available. So that's just what we did. So we thought it was better to have one technique, and we chose a scalpel bougie. And there's some interesting, this was an editorial that we wrote with, this is the president of the Royal College, and this is president of ENT UK, and I was representing DAS. And it was an interesting one because I think it's one of the few editorials I've written that's published simultaneously in ENT journal and in an anesthesia journal. And it's a recognition that when we're all in the same place, we all need to be thinking the same thing and doing it in the same way. And it applies, I think, across the board, actually. We wouldn't dream of going to a cardiac arrest, and everyone that goes there has different drugs and different CPR compressions and different ratios. So it makes sense that when we come to this, we all have a similar thought process around doing it, we thought. Okay, I'll finish off just talking a little bit about nasal high flow. So again, nasal high flow, this is a paper in The Lancet from 1968. So the concept has been around for some time, but the technology to deliver very high flows has only really been around for the last sort of 15 years or so. So what that technology involves is the ability to deliver 40 to 70 litres per minute. So that's a lot. Normally during anesthesia, maximum you'd go to is about 10, 15 litres per minute. So that's an awful lot. And it has to be humidified, because if you put cold, dry oxygen, so the oxygen that comes out of an anaesthetic machine is cold and dry. If you put that through the nasal mucosa, it dehisces, it tears, it bleeds, it's acutely painful. So the warming and the humidification is there to allow us to tolerate it. If the human nose could tolerate cold, dry oxygen at 40 to 70 litres, we wouldn't need any of this, but it doesn't, and we do. There's many, many publications, over 400 publications on the role of high-flow nasal oxygen in very prestigious journals around the world. It's a very standard technique for spontaneously breathing patients, and it's used in the intensive care environment, it's used in respiratory care, it's used in pediatrics, it's used in neonatal intensive care. And we published this article in 2015, but essentially the Fisher and Paykel people that make this equipment, that make the Optiflow equipment, came to us in 2013 and said, would you like to use it for recovering patients? And we thought it was a reasonable idea. We thought also that it might be useful what happens if you use it as a pre-oxygenation tool, and there had been some work around that. So we put it on a few patients, and we found that actually the sort of seminal case was a trainee who was really struggling to put a tube down on a patient, and a period of about 10 minutes went by, and the patient I would have expected to desaturate actually maintained their saturations, and they were paralyzed, so they weren't breathing. And so we thought that was interesting, and then we carried on using it, and over a relatively short period of time, around about 6 months, we started using this as a pre-oxygenation tool for placing a tube, but also for surgical procedures. So we were doing 15, 20 minute, 25, 30 minute surgical procedures in a paralyzed patient with this technique. We gave it a name, which is called Thrive, and the reason it's called Thrive is because it's transnasal, because it goes through the nose. It's humidified, because it's humidified. It's rapid insufflation, because it's 60, 70 litres per minute. And the key is this term here, ventilator exchange. We recognized very early that we knew that if you put oxygen in, you might be able to keep the oxygen saturations up, but the carbon dioxide would go up. And I'll tell you a little bit about that, but we recognized that there was some CO2 clearance as well. So my own series is on Thursday, we just did 1,012 patients, and we haven't analysed the last 400, but the first 600 patients, the average apnea time was just over 31 minutes for microlaryngeal procedures. So that's our series. And this is just to recognise the difference in terminology. So if you're breathing spontaneously, if you're sedated and breathing, if you're general anesthesia breathing, then that is nasal high flow. But if you're apneic and you're not breathing, then that becomes, we think, the term Thrive. So, some examples. So this is somebody who's in extremis, and we find it's really useful for emergency airways. Immediately they'll feel better. They do. And it gives us some time, once that patient is asleep, so there's obviously something going on here, there's a very small hole here, and the trainee is going to place this tube, which they do, and it takes them a little time. And we've got time to be able to do this. So we've got time to be able to put this in. Now, it doesn't always work, and it's not 100%, so I'd hate for you to go away and say, well, that's it, I don't need to think, and I don't need to bother about anything. You still need a backup plan if this doesn't work, or if the patient desaturates. And what you'll notice is she's eventually got a microlaryngoscopy tube in, and it's taken her 13 minutes of apnea. And this patient's saturations are still 100%. And I'm not aware of any other technique that will do that. I'm going to skip through a few things, other than to say that the FiO2 has to be 1, as long as the nasal flow is greater than the peak inspiratory flow, because otherwise he'd be drowning. It's very useful for awake fibre optic intubations. It's obviously very useful for the laryngoscopy component of placing a tube. And then this apneic ventilation aspect, this idea, so this was just some early data. This is CO2 and this is time. And this is what one would expect from all the literature, and this is what we found in our data early on. And then that work's been replicated by other centres around the world. So this is a similar rate of rise from a centre in Sweden, from the Karolinska in Sweden. This is a similar rate of rise from a centre in Scotland. This is a similar rate of rise. This is a similar rate of rise from Pierre de Munch's group in Strasbourg. So there's multiple centres around the world that are replicating our initial work. So we're pretty sure that our CO2 clearance is a real phenomenon. So this is if you just put low flow in, and this is how much the CO2 goes up by, and this is what we found and what other centres have found subsequently. Our first 600 patients, so the reason I put this up is just to remind us that it doesn't always work. So like with everything in medicine, it's not 100%, and there has to be a backup. So this is for phonosurgical microlaryngeal procedures where we're using it, and most of the time it works, but for these reasons it doesn't, either due to desaturation, and that desaturation can be 15 minutes, 20 minutes, whenever it is, but we haven't done the whole procedure with it. It seems to be pretty comfortable for most patients. When you look at end-tidal CO2s, 30 minutes seems to be a reasonable period before we start getting worried about the CO2 clearance. In anesthesia, it's now, I think, recognised as a very useful tool, and certainly in management of obstructed airway, it should include high-flow humidified oxygen. Airway obstruction is revolutionary and should be available. It should be available, I think, for airway obstruction cases, because it really does help. It's very obvious when you put it on somebody that it's helping. I'll skip these just for time, but these are ladies who's come in with really bad airways. Actually, I think you probably see it on here. And as soon as you put it on, they just feel so much better. It's just so obvious. Every single airway patient who has Stridor and you put it on, they immediately, you can hear it and they feel better. And this lady's got obviously a tight hole, and she feels better. And this lady's the same. And again, she's got quite a tight hole here, and she just feels much better. So that's the kind of differentiation in terms of the physiology around nasal high flow to Thrive. These are more patients with emergency airway obstruction. This is, again, just showing that after a 20-minute apneic period in someone who doesn't have much of a hole, the oxygenation is very good, and the CO2 clearance is there. And finally, just some very exciting, very recent work, just being published a couple of months ago. We spent about 3 years doing this, working out why are we clearing CO2, because there isn't anything in the literature that describes it, and we think we know why. This is the paper. It's open access. Actually, all these papers are open access, so you can download them if you want to. We did a whole series of experiments and looking at the physics of Thrive, and basically it produces a very significant airflow at the top end. It produces at the vocal cord very small flow vortices, and you'll see it here. So this is a paralyzed patient, and that movement of the string is the flow vortice. And the combination of that with the cardiogenic movements inside the lungs that the heart makes, that combination brings the CO2 up to about here, and then these movements get transmitted down, and that is what we think is clearing the CO2. So that's cardiopneumatic movements, and you see that all the time, obviously. So that, we think, is the mechanism. And a good demonstration of that is, this is the same patient, that's without Thrive, and that's with Thrive, and you see the CO2 drop down immediately. There's lots of work going on around the world. There's over 100 registered trials. I'll finish with this, which is to say that it's a fantastic tool, but it isn't 100%, and it can fail. And it can fail because of total airway obstruction, or it's severely limited in super morbid obesity, so BMIs of over 50. It's not a rescue tool, and it's not a substitute for good thinking. While I'm here, I thought I'd take the opportunity to invite you all to the World Airway Management Meeting, which is in Amsterdam this year. So this is an international meeting of 3 of the world's airway societies, so the UK Difficult Airway Society, the US Society for Airway Management, and the European Airway Management Society. So that's all the airway anesthesia societies. And India is represented, and China is represented, and Australia is represented, and South Africa, and Africa is represented. The first one, we had 1,700 participants in Dublin, and this time we're expecting a similar sort of number. So it should be a really good meeting. Thank you for inviting me.
Thanks, Dr. Patil. Very nice illustration indeed. And so many of our queries you have solved, so many are remaining, so I'll come to that. He carried us through the distorted airway, awake medical intubation, anesthesiology intubation, awake surgical intubation. The important take-home thing was cast of blood, which we never think of. Small blood platelets springing into the airway, and then they forming a cast, causing postoperative obstruction, surgical emphysema as a complication, which we illustrated well, and pneumothorax. There are so many things he said about Thrive, the basic essentials regarding blue and dye and reaction of the team, which are similar. Physics of Thrive you explained very well, and the BMI, be careful in BMI. Now, sir, there are so many queries with us. One thing is regarding, when I was talking about a few minutes ago with one of my anesthesiology friend, he said, anesthesia, we have to take care only 3 things: give oxygen, wash CO2, and maintain the pH. So that's absolutely a very, a crux of this particular thing. But then there are some things. For example, our friend Dr. Sachin has devised some innovative techniques. I'm coming to that in the end. high frequency jet ventilation, and now the Thrive. Thrive is of course far away from us, but then high frequency jet ventilation is there in few centers. But most of them are not having high frequency jet ventilation. So what they should prefer, a low frequency jet ventilation, what are the pitfalls of that? Or you can say the tube in and tube out technique of Dr. Sachin Gandhi, which has worked very well, and anesthesiologists were not aware of that. I told my anesthesiologist, Dr. Sachin is doing this. They were aghast, and then I told them, let us do it. And it worked, and now they are doing very often. So tube in, tube out technique, low frequency jet ventilation versus HFJV and Thrive. So what are your take?
So the tube in and out technique, it's called an intermittent apnea technique. It's described, I think in the 70s it's been described, and it's described principally for pediatric use. So most pediatric airway work is done breathing spontaneously, but for example with very severe papilloma patients, breathing spontaneously, they can still obstruct. So the TRIZA technique, where they put a small tube down, they hyperventilate for a period, get the oxygen up and the CO2 very low, they pull the tube out, and then the surgeon has 2-3 minutes to operate, and then the saturations come down, they go back in again. So it's a well-described technique, and it works very well. We tend not to use it. I think it's used more for pediatric, in pediatrics still, actually, sometimes. I'm not particularly experienced with that, but I understand the concept of it, and it works very well. I guess it will be very dependent on whoever's placing the tube intermittently. So if the tube is going in 3 or 4 times, then we probably need to be careful that we don't traumatize what we know already is quite significant pathology. So that's a very established and recognized technique. Low frequency, high frequency is really interesting. So low frequency is classically described as less than 60 hertz, but actually I think we all mean it's about 15-20 breaths a minute. So low frequency is effectively big tidal volumes, 500-600 mil tidal volumes, and it just looks like somebody breathing normally. So that gives you good CO2 clearance, and it's a very good technique. As you get to so high frequency can go up to 600. That's what the jet ventilators can do. For most airway work, about 100 is about right. If you get to about 200, you actually get breath stacking, so it makes it inefficient and the alarm keeps going off. So up to about 100 is good. Now the difference between 20 and 100 is there are 6 mechanisms for jet ventilation. So when you breathe normally, you have what are called big tidal volumes, so bulk movement. Then there is something called convection. There is Pendeluft effects between small alveolar movements. There is diffusion effects, convection effects, conduction effects, and there's one that I always forget, Taylor-type dispersion, that was it. And so the reality is nobody knows exactly of those 6 mechanisms which ones are happening as you increase the frequency, because nobody can measure it, because if you jet somebody and you put a probe into the lung, you immediately affect what you're trying to measure. So we don't know, but there are the 6 mechanisms. As you get to higher frequencies, the tidal volumes are getting smaller. At about 100, the tidal volumes are about 150, 200. So you can still see movement. But the distal airway and the clearance of CO2 is going to be dependent on diffusion, principally, and the other mechanisms I've just described. The advantage of 100 over 20 is that if you have areas of lung that are not very good, the higher frequency will clear CO2 better and get more oxygen in. So that's the advantage of it. And advantage surgically is that if you do low frequency, the vocal cords are going to be doing this each time. Whereas with higher frequency, it's much more subtle. So if you're operating on the cord, it'll be a more subtle effect. And if you're lasering, for example, you're not chasing it around. It's a bit more subtle. Yeah.
Very nice summarization, Dr. Anil. There are a few online questions here. Dr. Shishir Agrawal asks, there are 3 questions in one, so please take them one by one. How to use Thrive in tracheostomy patient? That's one. Protocol to start Thrive for airway surgery. So they want to know how to go about it. And how can we use Thrive while planning to do a nasal fiber optic oral insufflation using I just could not get this nasal fiber optic, but then I think you can better understand that. So all these 3 questions together from Dr. Shishir Agrawal.
Great. So I'll tackle the last one first. So that, if you can see, is I think what you're asking, which is how do you use it if you're doing a nasal intubation? So there's a number of papers on this actually. The first was from Guy's Hospital in London from Imran Ahmed's group, and they are real experts in awake tracheal intubation. So effectively, everything is the same. You put the cannula on and you put the fibroscope through. And the thing that people sometimes can't quite appreciate is that this cannula is very soft. It's a very soft silicone device. So it's easy to place the scope and a tube around it. It just moves out of the way. So effectively, you're doing exactly the same thing that you would do, but you're using this. And what this does is that it maintains the oxygen levels extremely well. I didn't put the paper in to show that, but Imran did a before and after group, and before the saturations can fall, with it they generally stay at 100. And they've just published another big series on that, and it's saying the same thing. There was also at the last DAS meeting, there was an abstract where I think there are about 70 world experts in awake tracheal intubation were asked what they do for oxygenation now for their nasal fiber optics, and the majority are now using high flow nasal oxygen because they've all seen that it just makes everything smoother and better. So that was very good. I can't remember the first or the second question.
Yeah,
first question was actually how do you set about MLs? Yeah.
And protocol to start the
Okay, so tracheostomy patients. So if by that you mean what do you do in terms of you have a patient that you're going to do an awake surgical tracheostomy on? No.
He is meaning to ask, can we use that technique through tracheostomy and a tracheostomized patient?
So there is an adapter that goes over, but that is not for apnea and for a surgical procedure. That is for a patient who is in intensive care, who is breathing, and who needs warming and humidification. So that's what that is for. It's not for...
Essentially, in a tracheostomy patient, we don't need thrive.
The airway is secured.
Yeah,
So it wouldn't
so
be for that.
That's it.
And the third question was...
In short protocol for starting.
Sure. So the first thing I'd say that if the use of Thrive for prolonged airway procedures, 10, 15, 20-minute procedures, is a very advanced technique. So before you even get to that, I think you've got to use it on normal patients. You've got to try it on yourself. You've got to use it as a pre-oxygenation tool. You then move on to perhaps using it for rapid sequence procedures, using it for a guide whilst you're intubating regular patients. So you've built up an experience base at a few minutes, 5 minutes, 10 minutes, and then you've got, I think then that's the time to go into a longer procedure. But it's not something that you just go straight into on the first go, because there's a lot of subtlety around it that you need to pick it up. It didn't take us very long. I mean, it took us a few months. But I think if you go straight into a half-hour laryngeal cyst, where the surgeon doesn't know it, you don't know it, it's going to be a problem.
It's going to, yeah. Longer procedure is going to be a problem. It's yet for less than half-hour things. There is a question from Dr. Deepati Maringati. She says, short neck, huge thyroid, on dopamine dip, IV clot, track tube in place, palpated, could not ventilate. Your opinion? Is possibly an anesthesiology question.
Sure.
See, all these things together and could not ventilate. So even track is in place.
Yeah, so usually if you can't ventilate, then even though you think it's in the right place, it probably isn't. So you need to confirm that. And you need to confirm that either by putting a fibroscope down there and just seeing. With trachees, as we all know, particularly the NT surgeons here, it's quite easy for it to just be in and just out and just in and just out. If it's a big patient with a thyroid and you haven't got an adjustable flange trachea in, you've got a rigid fixed structure, it may not be quite in the right place. So with the right positioning, it feels right, and then it moves out of position, and then it isn't right.
I think this question was, I'm unable to formulate it, but it is from Dr. Ramesh S. is formal surgical closure of tracheostomy tube recommended for pediatric trachs? I think it's related to Thrive. They want to give Thrive, and then possibly they want to. Is the closure of tracheostomies? I think
they're two separate questions.
Yeah. Can you get that question? Yeah, I heard it. Okay. Not related to this particular lecture. Okay, we can skip.
I don't know is the answer. You have to ask.
That's an ENT, typical ENT question. Yeah, so hardcore ENT question, I'll say rather. Dr. Rakesh Srivastava has asked 2 questions. Yeah, possibly yes. Can you use Thrive to hasten the process of closure?
So it's interesting.
Yeah, that might be the question. Yeah.
So in the pediatric literature, it's not as convincing as the adult literature. So there's an RCT that compared children going off to sleep with and without, and what they found was that with Thrive, you got an extended apnea time, but they only did it to a maximum, I think it was 9 or 10 minutes. And they did not find CO2 clearance in the children. And there's another paper that's shown a similar thing. So in children, it may, so all of this is relevant to adults. Everything I've said, I should have clarified that at the beginning, but it's all to do with adults. In children, I don't know, I don't think we know what the age limit is. I would imagine that we're talking about small children, infants, neonates. It's not going to have the same effect in terms of CO2 clearance, according to the literature at the moment. It will have, or it should have some effect on the apnea time, but I don't think people are using it for the actual procedures for this. It adds a benefit if you're breathing spontaneously, but not during apnea. Yeah. So I should have clarified that. So in children, it gives an extended apnea time. The literature to date does not suggest CO2 clearance, and we're repeating some of the laboratory work that we did on the mechanism in children to see if there is a reason, and the reason will probably be that a lot of the flow vortices and the mechanism that transmits up and down, because the airway caliber is so small and because it's so much more compliant, that's why it may not be quite as efficient or effective.
Yeah.
So I guess it is difficult to use that in awake children.
So where it's, I think, revolutionized pediatric practice is patients coming in with croup that used to go into a big box. If you put them on, a significant number of them don't go on to get some of them still will need intubating and going to an intensive care unit, but many of them don't. So that group of patients, so if you have a spectrum of patients, they're from good to really bad. The really bad group, it may not be particularly useful on, but that intermediate group, it might make them better rather than get them divert towards the bad end of the spectrum. So pediatric intensive care, neonatal intensive care, it's used a lot and it seems to work. But they're all breathing spontaneously. The anesthesia uses are different.
Yeah.
It's all breathing spontaneously.
Yeah, we're going from anesthesia to ventilation.
Exactly.
Yeah. Well, there are 3 questions from Dr. Manish Munjal, Delhi. I'll put them together and you answer one by one. The role of Thrive in tracheal reconstruction surgery is first question. Then role of Thrive in middle third tracheal stenosis, where emergency surgical tracheostomy is not possible. So you mean to say tracheal stenosis near the sternal parts, where emergency tracheostomy will be rather difficult. And then the third question is, how does Thrive work in laser surgery?
So in terms of tracheal stenosis, so we have used it in tracheal stenosis, and occasionally we need to jet on top of it. So if you're using it for tracheal work, you still need a plan B.
Okay.
It works, in our experience, most of the time, but occasionally it doesn't. And it usually is in obese patients. If they go head down, then it becomes a problem. Then we need to jet them more formally. In terms of tracheal reconstruction work, I think it depends on what kind of reconstruction it is and exactly what we're doing.
I think the same things will apply, the tracheal stenosis, because reconstruction is done for stenosis. If he is not tracheostomized, if he's tracheostomized before, no question of the routine anesthesia will be there. So if he's not tracheostomized before, then He might be thinking up to what level we should use Thrive. And after resection anastomosis, after we get the access to lower trachea, we can intubate and do the routine way.
Sure. So that's
yeah.
exactly. So there may be some uses for it there,
Yeah.
but again, that the person who's asking the question will be very experienced because they're doing that kind of work.
Yeah.
So they will have the ability, if it doesn't work, to have a plan B and a plan C, and that's the key. So what you don't want is the non-experienced person thinking that, well, all I need to do is this, and then not realize that actually it isn't 100%, and then I need to do something else, and they don't know what to do. And in which case, don't use it. Just carry on doing whatever you're doing. So there's got to be a backup plan for all of these things. And the third question was about
the
lasers.
third question was regarding lasers.
Yeah,
Most
so
of it you have covered already, but then
Sure.
finer points.
So the laser uses is very interesting. So when we started using this, we did use lasers with it, as if you're and the people who are using lasers are very familiar with a fire triangle. So to have an airway fire, you've got to have 3 components.
Yeah.
And the people that use lasers all the time are very, very, very comfortable and confident with that. As you started expanding, we became more and more conscious of the fact that more and more people who aren't laser experts, inverted commas, or aren't doing it every day or don't understand it as well as the laser experts do, were starting to use it. And we got very concerned that if you're not 100% all of the time, with 0% error rate, always aware that you can never put a foreign material into that field, there can be a problem. And on that basis, and on the basis that we were aware of there was one case report of somebody using Optiflow for an obturator with bipolar. You should never use bipolar with oxygen.
Okay.
It's a bad combination. There was a fire and another report. So we got concerned that as its use expanded, people who weren't laser experts would start using it and run into problems. And so we actually said at that time that we think that we shouldn't be using it, because then you have no complication rate with it. That doesn't mean that laser problems aren't going to occur. In the United States, there are approximately 600 airway fires in operating rooms every year. You don't hear about any of them because no one advertises an airway fire. So they happen and they go on. We don't want it to be related to this technique for other reasons.
Yeah. Another question is it's related because that's why I'm taking it in the beginning. Dr. Abhinay Harankhedkar, he is asking, is there any barotrauma due to Thrive? We know barotrauma because of LFJV and sometimes HSJV. Now, is it Thrive?
No, it isn't, because if you, well, we don't believe it is, and we certainly haven't seen it. There's quite a high flow rate up here, so say 70 litres per minute.
Yeah.
That equates to about 7 centimetres of water pressure, which isn't very much at all. And when you start coming down here into subglottis trachea, it's much lower than that. So I'm pretty sure that you can never say never, but there's no kind of tracheal airway barotrauma related incidents.
Yeah.
2 exceptions to that are, one, if you have a head trauma or a skull base fracture and you put in 60, 70 litres per minute, then you can get air entry.
Pneumoencephalus and all those things. And even you can get...
And the other time that you can
air
get
in the
barotrauma is if you have, for example, 70 litres per minute going through, and the safety is because it leaks out around the orifice and it leaks out of the mouth. If you then put a face mask over all of that, it's quite difficult to do, but if you manage to get a complete seal around this with 70 litres per minute coming in, then your pressure will build up. So they're the 2 situations where it can happen. So we're very careful. We always, if you ever check face mask ventilation, you have to take the Optiflow off from the nose up to here. Then you put this on. Then you check.
Yeah. Sometimes inadvertently people may do it. If it's not being ventilated, oxygen is still going on, and then they are ventilating manually. Of course, they said that barotrauma most often occurs because of unrecognized obstruction, and that leads to catastrophe. So thank you, sir. Now the next question is from Dr. Rakesh Srivastava. How frequently do you do Thrive in post-op patients?
Now,
again, going on ventilation rather than anesthesia.
Hello, Dr. Rakesh. We for airway work, we tend to put laryngeal masks in for recovery. And the reason we put laryngeal masks in is because we have a complete seal, we have protection from secretions, and we can sit the patient up and we can give some degree of CPAP if we want to. The real recovery advantages are it will provide advantages in terms of oxygenation for anyone post-operatively. And there's some really good literature coming through, or has come through over a number of years, post-cardiac patients, post-thoracic patients. It's reducing length of stay in hospital by having this on for a period of time afterwards. So the fact that you can put this on, the fact that the patient's PO2 is higher, CO2 is lower, tidal volumes are better, they get less basal atelectasis, they re-recruit areas, particularly after thoracic and cardiac surgery. That all improves their outcomes.
Recruiting more and more alveoli.
Recruiting more and more. So it has definite advantages in groups for recovery. For the airvo, yeah. It's a slightly different term.
So there are another questions from Rakesh. One is related recent question. Is TRI effective in postoperative recovery in pediatric endoscopic airway surgery?
So I'm not aware of...
that means recovery is easier or what?
Yeah, so there's a number of abstracts and papers looking at during the procedure. I'm not aware of anyone looking at it afterwards, but if the mechanism for during is the same as the mechanism afterwards, I think it should be, but I don't have any papers to support that.
Yeah, and then there are two related questions from him only. One is, how frequently are you using HFNC in postoperative cases, and how do you compare Heliox and HFNC during acute rescue phase in ER?
So we don't use Heliox actually anymore. I haven't seen a cylinder of helium for years now. Two reasons. One is Heliox was a fantastic tool 10, 20 years ago because it, as you know, it reduces the density, so you can breathe more and get a bigger volume, but at the expense of the fraction of oxygen that you're inhaling. This does as good, if not better, with maximum oxygen. So my view, and certainly from some of the stuff I've showed you, I hope it shows that actually many people are thinking the same thing, that if you've got airway obstruction, this is what you should be using as a holding maneuver. It's not a rescue maneuver. And the very important aspect to this is somebody comes in and they've got a tumor and they're stridorous and they're unwell and they're tachypneic and hypoxic. You put it on, they look better, their stridor's much better, they feel better, their oxygen levels are better, their CO2 is better, their respiratory rate has come down. But you have not done anything for their underlying pathology. So one of the dangers of this is that you put it on and everyone walks away and goes, oh, the patient's fine now. And of course they're not fine. This is a holding maneuver to alleviate the underlying problem, which may be adrenaline nebulizers, steroids, etc., and it shrivels away and it gets better. Or if they get worse again, then you're going to need to do something. So we just need to bear that in mind as well. That when you put somebody on helium, it's very obvious that this is an immediate holding maneuver until I secure that airway. When you put people on nasal high flow, because they look so well, you think the problem's gone, but it hasn't gone.
Yeah. Very interesting questions coming in. I'll go to the first question. Dr. Rohan Bidai, he's possibly presently in UK itself, is asking opinion on twin stream jet ventilation system.
So for those of you that are not aware, twin stream jet ventilation is made by Carl Reiner. And effectively, most jet ventilation tools are single jetting. Twin stream is two jets. So the idea is that you can have a high frequency and you can have a low frequency. So the low frequency gives you big tidal volumes, and then superimposed on those tidal volumes, you have a very high frequency. So I think it's a very good tool, actually. A number of things are the reasons that we trialled it, I can't remember, 10, 15 years ago. And in our hospital, it wasn't appropriate for the simple reason that in Germany and Austria and Switzerland, their pipeline pressures, so the pressure at which the oxygen gets to the machine, is running at 5 or 6 bar, so 5 or 6 atmospheres pressure. I don't know what it is in India, but in my hospital, it's 3.5 bar. And the problem is that for the advantage of a twin stream, you need the higher bar pressures to really get the advantages of it. And if you're only putting in 3.5 bar, we didn't get the advantages of that, or we didn't feel that. And the other reason we didn't was at that time we were doing sometimes 10, 15 microlaryngeal procedures a day. And for the twin stream, you need a specific laryngoscope, and we couldn't afford 15 separate individual surgical laryngoscopes, to be truthful. It was so there was a number of reasons why we didn't adopt that. But I recognise it's a really good tool. There's good work on it, and if you have high pipe pressures, it's a good thing to do.
Yeah. There's another question from Dr. Manjunath. And also, this I have faced many times in the past. One of my emergency tracheostomy under ALA for Strider went for negative pressure acute pulmonary edema and was revived successfully. Would Thrive prevent such a complication? I'll add my own things to that. I have faced this situation in foreign bodies. Whenever the foreign body has swelled, has slipped into the subglottis and totally blocked, and thereafter it develops acute pulmonary edema. I had to retrieve it by doing tracheostomy thereafter. And when I did the tracheostomy, I found that I'm sucking literally fluid out of the airway. So for minutes together, we used to suck, and then we go in for. So he has done this. Possibly there was a partial, maybe grade 3, you can say, Cotton-Mayer obstruction, did tracheostomy, and during that phase, total obstruction precipitated, that developed acute pulmonary edema. Would it have been prevented by Thrive?
I don't know, is the answer. It might have helped, but I don't know. I mean, the foreign body reactions are horrible. Kiddies, they're terrible. And it may be that for those individuals you need kind of a number of different things going on. I mean, the classic kind of if you read the stuff in the books, it says that you should keep the patient breathing spontaneously because you don't want it to get pushed down. The reality is that if you've ever done this, quite often you cannot keep them breathing spontaneously because they just obstruct, and you have to take over. So so anything that can help in that process is useful. So it might have helped, but I don't know whether it would have done. I don't think anyone would.
Thank you so much. Thank you, Dr. Anil Patil, and now I'll come to Dr. Sarang Puranik. I think we will take the last question now. He has been asked a question, a role of preoperative coagulation profile before adenotonsillectomy. The question has been asked by Dr. Ramesh S. He is pediatric anesthesiologist from Chennai.
As far as the selection goes, I think that gets sorted because that's what I was saying. The pre-op selection is very important. If you have any, we don't obviously take those patients if they have any coagulopathies and issues, but we routinely don't do any tests. So if they're talking about whether we do check their routine bloods, we don't do any routine bloods unless there is any indication. So it's very rare that they are not picked up.
History of PTK or
exactly, anything, absolutely, or if they've been already under hematologist for some reasons. Otherwise, there are ASA 1 and 2 patients, so that helps.
I sometimes feel that UK is a developed country where if he is having coagulopathy, he is already under some other investigation. Yeah. We may not get such a situation in India where that might be a first case and he has been unrecognized. So the situations differ according to geography.
Of course, but I think that's where the pre-op assessment helps, and that is wherever you do, I think that will certainly help. When you start, if you are thinking of starting here, if you select the patients before, and most of the questionnaires, if you ask them right questions, you will get to know a lot of information. And in pediatric population, obviously, if they have coagulopathy diagnosed, it will be much earlier anyway. So hopefully that would have been picked up.
Thanks, Dr. Puranik. Handing over to Dr. Sachin Gandhi.
I mean, we are coming at the end of this section because a lot some questions are coming over. Maybe next time we can answer them, or by email we'll revert back to them. I would like to first thank Dr. Anil, Dr. Sarang Puranik. I mean, Anil has directly come from the airport with such a long journey, and I really thank him very much for a wonderful lecture here. I would like to again thank Dr. Sarang. He's my batchmate and my colleague in BZ Medical and during my medical education. Thank you very much. uh, best moderation and one who does airway surgery quite often in government general hospital, Dr. Samir Joshi, very much appreciate your contribution to this, and I think it has made really the whole interaction very successful. Thank you very much. I would like just to let you know about our founder of, or maybe a pioneer who has pioneered laser surgery in the UK, and maybe our boss and who has initiated this whole laryngology in the Nanath Mangeshkar Hospital, Mr. Vasant Oswal. He is a pioneer, and maybe he has invented Oswal-Hunton metal endotracheal tube, which is actually very useful for laser surgeries. It's an uncuffed tube, and I think there are many articles published. So maybe apart from his contribution in laser surgery, his contribution in anesthesia also would be good to introduce at this particular interaction between anesthetists and the ENT surgeons. He's also there, I think, on the for your webcast, and he has given his compliments and everything to you. I would like to introduce, most important, the anesthetist with whom I work, and that's the Dr. Vinayak Desurkar. He's a senior anesthetist. He has moved into cardiothoracics department, the whole anesthesia department, and headed by Dr. Jitendra Shirsagar. He's a senior anesthetist again, and Dr. Prerna is a young anesthetist who has joined. But I think because of these people, really we can do lots of surgeries in airway for last almost 20 years, and maybe we are able to invite these people and have access to come a long distance here and be here. I'm very glad to maybe tell you about, I'm getting the WhatsApp messages from Bangladesh, from Singapore, from Nepal, from Philippines, and lots of centers in India. Gangaram Hospital in Delhi, I think there are intensivists, anesthetists, and ENT surgeons together, which have arranged they are in the seminar room there, and I would like to thank them, as well as Dr. Manjunath from Bangalore, Calcutta, and many parts of India. I think they have participated and made this a successful opening of our webcast series. Thank you again, all of us and all who are present here, the students and lecturers from Sassoon General Hospital, my fellows, and all other participants. Thank you, and hope to see you again in near future. Thank you very much.
I think I should say some words about Sachin, at least for our group here. I don't know whether we are still live or not. You don't need to be live. You don't need to be live, but I think the credit, is it cut, yeah? The credit, I think, ultimately has to organize this thing in such a short period